All right, I'm going to go ahead and get started. Welcome, and thank you for joining us tonight. I'm so glad you're here with us at this evening's Ask the Experts live webinar with Dr. Alexander Volchonok. Dr. Volchonok is the co-founder of TetraHealth Dentistry and dual Ivy League trained Biologic board certified periodontist and oral implantologist. He has advanced training in zirconia dental implants, pinhole gum rejuvenation, and LANAP, and he's one of the only periodontists in the US formally certified in biologic dental surgery after completing his residency through Tufts University and in Frankfurt, Germany. Tonight's topic is a biologic roadmap from extraction to root canal teeth to zirconia implant rehabilitation. Dr. Volchonok will be guiding us through what a truly biologic approach looks like, from evaluating compromised teeth, performing extractions in a way that protects your long-term health, to rebuilding with zirconia implants and biologic regeneration. So we're going to leave time for your questions at the end. We do all of the questions the last 15, 20 minutes of the webinar. There is a Q&A button at the bottom of your screen that you can drop your questions in throughout the entire lecture. I will be receiving them, and at the end, I will read them out loud, and Dr. Alex will have a chance to answer your questions live and give you some feedback. So I will go ahead and let you get started, Dr. Volchonok. Thank you so much again for being here with us tonight.
Thank you so much, Kim, and it's an honor to be here with the entire Aura Biologics community. This is such an enlightened group of individuals to be able to speak to on the concepts of biologic dentistry. So I'm really excited to share my topic here. So let's hop in. I'm sure we're going to have lots of questions and lots of things to talk about. So just confirm for me that we see things pretty well here, that everything's
Yep,
open, right? All right,
we can
excellent.
see it good. And then what I'll do, just so I can give you the floor, I'll turn my mic and my video off. And if you need anything, just let me know.
All right, excellent, excellent. Well, thank you everyone for joining us. And this presentation is right on the heels of Thanksgiving. So for those who are celebrating, happy Thanksgiving, and thank you for donating a little bit of your long holiday weekend to me and being able to share this very, very important topic with everyone. So the presentation is a biologic roadmap from A to Z. And what I mean by that is we're going to be talking about everything from atraumatic extraction, especially of root canal compromised teeth, all the way through zirconia implant rehabilitation. Kim gave a beautiful introduction to me, but what I'd like to just really highlight is I feel very unique in that I have a very, very strong education in terms of what we consider traditional dental or Western education, dual Ivy League trained between University of Pennsylvania and Columbia. But I've always been very passionate about biologic dentistry and learning concepts from across the pond, traveling to Europe throughout my entire residency. And I've been very, very happy to be part of the first ever maxi residency program here in the United States, where there's true certification in biologic dental surgery. And I'm the first periodontist to complete this. I love learning and I love bringing that forward. And that is the basis of what I do in our practice. I'm a full-time private practice clinician, which means every single day of the week, I'm taking care of people just like you that have real dental issues, and I apply my knowledge in the healing arts with them. I do not practice alone. I have the honor and privilege of being the director of a specialized team of biologic doctors. There's five of us. I practice alongside with my co-founding partner, my sister, Michelle Volchonok, as well as specialists in prosthodontics and airway health, Dr. James Linkus, in orthodontics and craniofacial movements, sleep issues, and skeletal expansion, Dr. Lisa Jolly, craniofacial orthodontist, and biomimetic and restoratively driven dentist, Dr. Rowan Pereira. So this is a very unique thing that we've been able to bring together. And our mission is to help people by taking an integrative approach, combining the latest advances in dental medicine with holistic treatments, with biocompatible materials, and elevate each person's health and well-being. So that's what we're about, and that's what I'm going to bring forward in this presentation. I hope that there's a few things that we're going to get away from this. One is that I want to establish the biologic differences between healthy and failing root canal treated teeth. What is going on the biologic level that differentiates the two? I also want to help explain the key principles of biologic tooth extraction. What are the necessary steps? What should be happening literally from A to Z? And then we'll conclude with reviewing the advantages of zirconia dental implants and also look at this and apply this through clinical cases. So let's start with the first thing. So biologic differences between healthy and failing root canal teeth. So first and foremost, let's understand what a healthy tooth has. So a healthy tooth has an outer layer of enamel. That's the hard mineral white structure that we see when we open our mouth. That's the protective cap. That's the shield of the tooth. Then there's a more tubular layer called the dentin. That's represented by the yellow in the illustration here. And these are little fibers, little tubes that connect and give structural integrity to the tooth and also insulate the pulp tissue from within the tooth. And the pulp is a very complex structure. So a healthy tooth has what's called a neurovascular bundle, meaning that there's an artery, vein, and nerve that enters through the apex of the tooth. And a tooth has its own connective tissue. It has its own stem cells inside the area. It has its own reparative mechanisms and lymphatics. So this is a complex structure in a very, very small space. But when this is all functioning properly, this is what we call a vital tooth, meaning that it's alive. And we need to think about that. Every single tooth is connected through these nerves to parts of our brain. And the blood vessels are connected with our systemic circulation. So what happens in the mouth, and I'll say even more importantly, what happens in the tooth affects the entire body. So let's start talking about root canals. So we hear the term all the time, root canals, root canals, root canals. And I just want to kind of first of all say that it's a bit of a misnomer and we should be clear. So every single tooth has a root canal. A root canal is a natural occurring anatomy where the blood vessels and the tissues live within the tooth. That's this pink area in the illustration, and you can kind of see it highlighted and outlined on the diagram on the right. When things are healthy, this helps provide sensation to the tooth, provides blood supply, and allows the tooth to repair and deal with any kind of functional forces like the bite, or even if there is a cavity, this first layers of reparative tissue formation. But there's also complexities, right? There's the pulp chamber, which is the top part of this. And then it goes into these individual canals in each root, which is why we call it a root canal. And it will exit through the apical foramina or sometimes laterally through some of the lateral canals. So root canal therapy is kind of what we're thinking about as this dental treatment as proposed by the American Academy of Endodontics. It's defined as a multi-step process. So one, if decay has reached inside of the tooth to the level of the pulp, and the pulp tissues become inflamed beyond the point of regeneration, then a root canal therapy includes the steps of removing the diseased pulp tissue, including the blood vessels, the nerves, the connective tissue, then cleaning and disinfecting the root canals, and finally filling and sealing the cleaned canal system. So if you kind of look at that right side illustration, this pink filling material, the root canal filling, usually often is a gutta percha, and then subtype of filling material is a seal and a crown over the top. And the whole purpose of this procedure, why this procedure exists, is that its purpose is to eliminate bacteria from the infected root canal, preventing reinfection, with the idea of trying to save the natural tooth, so to speak. And if we look at the endodontic literature, and this is what a lot of endodontists will quote all the time, and a lot of dentists will quote this all the time, saying that, I don't see what the big deal is. Why do biologic dentists constantly talk about root canals? We say that they work, that 97% of root canal teeth survive between 8 and 10 years. And I want to kind of challenge some of that thinking, not with my own opinions, but I want to share some of the latest science, right? Because you'll see that this is an article from 2004, and this is what is still considered one of the gold standard articles that is cited in the dental community. So our dentists, conventional dentists, yes, they are experts, but they need to stay on top of literature and they need to stay on top of things that are out there. And so as an enlightened community, we want to ask those questions. So if a root canal was doing all the things it was saying it was going to do, meaning it was going to clean out the canal, it was going to disinfect the bacteria, it was going to save the tooth, then, and it had a 97% survival rate at 8 to 10 years, Well, then what would be the problem with this? Well, the reality is it's a little bit like this car. It's opposing biology. It's going against the natural biologic process of how our body wants to heal, just like this car is going against the flow of traffic. And so let me share some of these challenges, right? So first and foremost, a root canal procedure, a root canal therapy procedure is a very complex procedure, even when performed by someone with a lot of experience, such as an endodontist, because the canal systems aren't just simple tubes going down the tooth. There's a lot of accessory and lateral canals. If you look at the illustration on the right-hand side, there's actually been some studies now that have tried to map the pulpal tissue, and you can see outlined in red the pulpal tissue is not a straight line canal, but actually many, many branches and many different estuaries that come off of this pulpal tissue that would make it impossible to completely disinfect the entire canal system. Furthermore, sometimes the root anatomy is not a straight line. Sometimes there's very curvy roots that it's just almost impossible to get around those bends. And so these are some of the issues that we'll see anatomically. And also the procedure itself can have a lot of issues. If the tooth cannot be properly isolated, or if an instrument breaks while performing the procedure, if the filling does not reach the apex, or sometimes it breaks through the apex, what we call an overfill or an underfill. If the crown will leak, if there's fractures in the roots due to the post, or many other iatrogenic factors, meaning factors that happen because of the doctor working on the tooth, it affects that success rate, right? Meaning that the procedure is not going to work the way we're intending it to work. And because we know some of the bacteria gets left behind, even in the best of conditions, we understand that sometimes these bacteria will develop a resistance, right? Because the body's immune system, that blood supply, no longer has access to the inner components of the tooth. And as a result, pathogenic bacteria, like such as Enterococcus faecalis or actinomyces, or sometimes even fungal species, can grow within that tooth, creating a much more resistant infection, especially when it gets to leak out beyond the apex. And so these are some of the things that we see that make this more complicated locally. But I also want to talk about that root canal infections result in inflammation and immune activation, not just in the mouth and in the jawbone, but systemically as well throughout the entire body. Because what will happen is that microbes and toxins are going to start to trigger the immune response in our body. And our body's job, our immune system's job is to try to protect us. And what it's going to do, it's going to activate different cytokines like interleukin 1, interleukin 6, and different chemokines, interferon, and this is going to bring and recruit cells to that area to try to fight that infection. And it's going to start to travel through that bloodstream. Remember, we mentioned that that bloodstream of that tooth is connected to the entire body. And these inflammatory cytokines are going to start to activate inflammation in other organ systems. And recent studies from 2022 and even a new study in 2025 is showing more and more support, even within the endodontic literature, meaning the people who are advocating for root canals. They're saying that, hey, listen, we are finding that there is an association between endodontic infections and a higher prevalence of many systemic health conditions, including cardiovascular disease, diabetes, kidney disease, pregnancy issues, and even autoimmune disorders. So the response is not just a part of the mouth, but it's really a response of the entire body. And so it's very, very important to understand that if there is a root canal procedure that is being performed or being done on the body, then if that seal is going to fail, then an inflammatory response is going to create havoc, not just locally, but potentially in other organ systems as well. And, not to even take my word for it, but here is a systematic review from 2023. And this is looking at some of the later research. And I just want to highlight a few things that, a study in 2021 looked at the overall success rate of root canal treated teeth. And they found that that rate was actually 67%. All right. So overall success was much, much smaller than the number that was quoted in that previous paper from 2004, right? Saying that success rates 67%, survival rates 97%. I'll make a point about that just a little bit later. In another study that really looked at a large quantity of patients who got treated, over 3,000 patients, the results were even less impressive. Only 47% of the cases were deemed to be satisfactory based on the endodontist examination. So, what do we find to be an issue there? Well, the more complex the anatomy, or the more posterior, meaning the further the tooth is in the back, like a molar, the failure rates increase. And what I found to be most shocking is that really only 25% of molar teeth have a satisfactory result. So that failure rate starts to become really, really concerning when we start talking about root canal therapy. And when we look at it over time, longitudinal studies, studies that look at the long-term outcomes, when they looked at 5-year data, they're saying that there was really only a 36% survival rate for teeth that did not have a definitive restoration like a crown or if there was leakage there. So there's all these factors that increase the failure rates of root canal treated teeth. And the numbers really, through their own community, through their own research, are starting to show a very different story. So what's the takeaway here? Well, even though the endodontic literature that a lot of dentists have been taught in dental school and endodontists still preach of 97%, we need to understand that survival is not success, right? Just because the tooth is there doesn't mean that it's not sick, right? And that's like having a tumor, right? So if you have a cancer in the body, that is able to create a lot of harm to your body. It may even kill you. Even though you're technically still alive, you're still surviving, you're not thriving. And I'll kind of add an interesting point here. I went back and I read this article and I said, well, I'm just really curious to see like, why does everyone talk about this? And what I realized in their own discussion, I realized that there was a chart review, meaning that what they did was they ended up just going back and looking at the doctor's charts, meaning that it was not objective data, but it was subjective. It was whatever the doctor thought of the root canal. They said that, the reason why they chose this format was because they were worried that if they were to contact patients and contact the practitioners, they'd be reluctant to participate, especially if there was a unfavorable outcome. All right. And that they were concerned that it could lead to legal action. All right. And so this is in that own paper, kind of in the discussion there. So, this is a strong limitation of that, even though this is one of the most important papers in the endodontic world. It's important to know that this data is over 20 years old, and the more recent data is starting to paint a different picture, right? That root canals really are not as successful as they were thought to be before. And we need to be really smart about when those therapies are recommended, and also to be a lot more diligent about identifying a failing root canal treated tooth and treating it appropriately, which is the whole purpose of this lecture, right? To understand what to do when we see those things happening. All right, and so let's go into that. So the principles of biologic tooth extraction. So biologic extraction principles fall into kind of three components. When we think biologic, we think how can we help the body heal in the most natural way? How can we amplify the body's natural healing response? And what biomaterials can we use that will help facilitate that? So the first step is to follow something called an atraumatic extraction technique, meaning that we are doing an extraction technique that is aimed at preserving healthy bone and healthy gum around the tooth. We also will do a biologic detoxification of the sites to remove more of the bacteria to be able to penetrate into the fiber space and into the bone and into the tissues around the tooth, and to be sure that we remove the periodontal ligament. If you look at the image on the left, this is a cross-section histology of a tooth. And what you will see is there's a blue outline around the root in the middle that has a lot of horizontal lines that kind of go through it. And that's called the periodontal ligament. If a tooth is just removed, all those tissue fibers remain. And those tissue fibers prevent bone formation. So it's extremely important that that area is entirely cleaned out if we are looking to help the body reform natural bone in the area. All right. Furthermore, if you look at the image on the right, you can see how many different cells are activated in the site of inflammation and disease. Some of these cells, including the macrophages, which clean up disease and byproduct in the area, are important, but there's also osteoclasts. These are cells that remove diseased bone, and we need to help the body by removing this disease lining so that the bone can heal, so the body can heal. That's a natural mechanism of the process. And only after we've thoroughly detoxified the site should we then focus on a regenerative approach. And this is very critical. If we leave the site just to heal, or even just place PRF in there alone, PRF is platelet-rich fibrin, which is a common biologic practice, it does not prevent the volume loss or cavitation formation in these sites. And this is really a very important point, especially if there are any doctors here or anyone who's had a tooth removed, even in biologic method. It's important to understand that when a tooth is removed, that area needs to be grafted. We need to use a bone mineral graft in combination with PRF to get the optimal healing. PRF alone is not enough. So what are these steps? Let's zoom in a little bit here. So atraumatic extraction technique. If we are taking out a posterior tooth, like a molar, that means that there's multiple roots. And it's very important that we cut that tooth in half, or if it's an upper molar, that we trisect it, cut it into each individual root. This is to allow for a cleaner removal of each of the roots so we can help preserve the bone. It's also important to avoid raising any flaps, meaning elevating the gum off of the bone, because that gum is critical for preserving the blood supply to the bone. If we raise that flap, if we move that gum away, we will lose bone. All right, and so when the tooth is taken out, what we want to see is we want to see an image like we do here on the right, where we see the extraction site, the tooth is out, and the gum is fully intact. There's no flaps, no perforations, no need for suturing. And the bone in the middle is completely intact. And that's what we're looking at there. We're looking at something called the septum, which is the bone between the two roots. And if you follow an atraumatic extraction technique, that bone will be preserved. If you follow an aggressive extraction technique, that bone is often broken, or the outer white wall of bone called the buccal plate is often broken. And we'll talk about that more too. How can we do it? It's very important that if you have a biologic dental surgery, that the proper tools are used to facilitate an atraumatic extraction technique. First of all, there should not be large elevators used to try to wiggle the tooth because that's almost guaranteed trauma on the bone or breakage of the bone. Instead, there are newer devices like a piezo that can help do piezo scissions, which are atraumatic ways to separate the ligament from separate the tooth from the bone at the space of the ligament, and utilization of exotomes, which are very thin elevators that can reach into the space between the tooth and the bone to help remove that root. There's also special forceps that help grab the root deeper down at the level of the bone. And it's important to remove the root with a rotating motion as opposed to rocking it back and forth. All right. And if there's anyone here who's had an extraction before where the dentist has rocked it back and forth, this is something that a lot of oral surgeons are taught to get the tooth out quickly. That is almost guaranteed to break the outer wall of bone. It's a fast way to remove the tooth, but it compromises a tremendous amount of bone. And that's why it's a no-no when we're talking about atraumatic extraction techniques and biologic extractions. And then one of my mentors, Professor Gennady, always kind of taught me is, once the tooth is out, that's when the work begins. And I think this is really the mantra of biologic dentistry. All right. So many surgeons will focus on techniques to remove the tooth quickly and then move on with the next step, whether that's, a bone graft or an implant or just sending the patient out the door. But it's all about cleaning. The better you clean, the better the body can heal. And I want to talk about that. So, biologic detoxification. In our practice at TetraHealth, what we do is we follow the most comprehensive biologic detoxification protocol involving three different methods to clean the site. We will utilize mechanical debridement, where we'll use a spoon curette to remove any infectious tissue, anything in bulk. We will then use ozone therapy to disinfect the bone in the socket because ozone gas can diffuse. And then we'll utilize a laser to clean around that socket and remove that ligament tissue. And that will leave healthy, vital bone that can help facilitate that regenerative process. And this is the socket regeneration part. And this is a very, very important component. If we want to create proper healing and proper volume maintenance in that area, we need to use bone in combination with PRF. And I can't stress that enough because this is really a missed point in a lot of biologic dental practices. All right. And so combining the bone mineral, that allows for space preservation. PRF allows for better vascularization and better soft and hard tissue formation in that site. And so in this case, in this patient's case, we were able to place an implant simultaneously at the time of removing the tooth. And you'll see that the space around the implant is filled with a bone mineral graft along with PRF particles in there. And then the photo on the right shows that area with the PRF membrane over the top. So we create a seal that will exclude food and bacterial products while the soft tissue is healing. All right. And so in that case, you notice that there was an implant placed at the time of the tooth removal. And so this is another important conversation. And there's a lot of research that has shown that it is absolutely possible to place a dental implant in an area where an infected root canal tooth was removed. But it's very important to understand what parameters would lead to success and what wouldn't. All right, and so I'm going to kind of go through my thought process. I'll share my thought process here. So if there's an endodontically infected tooth that has apical periodontitis, meaning an infection around the apex of the tooth, like the image here in front of this front tooth, then the first question I ask myself, is this a chronic infection? All right, does the patient have minimal pain? Is there no periodontal infections? All right. If the answer is yes, then I'll go on to the next thought process. But the answer is no, meaning that this is an acute infection. There's pus coming from the area. The patient is in pain. That there's also periodontal problems in the area or gum infections in the area. Then we will extract only. All right. And that's really, really important to understand because in that case, if you put an implant in, the body's not ready to heal. It's too infected, it's too inflamed. Any biomaterial you will put there, you will lose. All right, but assuming that you have all those conditions checked, the next thing we have to look for is something called an intact buccal plate. All right, in this illustration, the green line on the outer part of the root, it's the thin bone that sits outside of the root that holds the root in place. It's very important for that bone to be intact, to be present in order to be able to place an implant simultaneously. This is why the atraumatic extraction technique is so important. It's so vital because if we are aggressive with the extraction process, then that buccal plate can be lost. And if you do not have an intact buccal plate, the only option you have then at that point is to extract. You cannot place the implant at that point. So with atraumatic extraction technique, we'll be able to preserve that buccal plate. And then it goes to our final question. Is there enough bone present apically, meaning beyond the apex of the tooth, that we can anchor an implant in for primary stability, meaning that we can have that implant be stable with the aid of that bone. If not, then again, extraction only. But if we do have it, then in that case, we can place a ceramic implant, a zirconia implant, and that will allow us to be able to save the patient a surgical step. All right. It often helps also save from a financial standpoint because they will not need to go through multiple surgeries, and typically halves the healing and recovery time from the removal of the tooth till the patient will get a final tooth. All right. But it's very important not to rush that process. And as a patient, I know we want to get the teeth back as soon as possible, but it's important that it's done the right way. It's done the biologic way because what we're looking for is long-term health and long-term success. All right. And this is kind of that thought process that your doctor should be going through. This is the thought process that I go through. And I want you to know this too, because this is an important aspect, this important checklist as to how those decisions get made. All right. And let's kind of now talk a little bit about the advantages of zirconia dental implants. So zirconia dental implants offer several important advantages, but what I'll share is that this has been kind of an evolution over time, right? So we've had titanium implants, and that's really kind of the standard implant, pretty much since the 60s. And although the materials have changed, the titanium implants today are mainly alloys, meaning they're a combination of multiple different metals. There's over 350 different titanium implants on the market of various quality. It's created a situation that this is not really the most biocompatible material. And so we've been looking, how can we create better biologic materials? And it started with the abutments, meaning the tooth that would go on top of the implant. We were able to first create a zirconia ceramic crown, then a zirconia abutment. And then the materials got strong enough that we've been able to create really predictable zirconia dental implants, both in one piece design, meaning it's a single component from the abutment to the threading that goes into the bone. And now even new generation implants that are a two-piece design, meaning that there's a part that can go in the bone, and then later we can make an abutment that can go on top. And so the versatility is really there. And this has been the evolution in thinking in the biologic dental world. Even though we've known about the benefits of zirconia implants for a long, long time, zirconia implants have really required an evolutionary step because older zirconia implants would fracture and would break. And unfortunately, a lot of conventional dentists are still fearful of zirconia implants because they think it's the same ceramic as before. All right. And it's part of my mission is to educate them that that's really not the case, that this is a very predictable material. And also, it's a much more biocompatible material. So, whenever possible, I'm sure I'm preaching to the choir here when I say, zirconia implants are really the way to go, but this is not mainstream knowledge yet. And, I thank you all for really being ahead of the curve. But here's some of the main benefits. So when we think of zirconia implants, of course, they offer the superior aesthetics, right? They're not a gray implant. It's not a gray abutment. So the soft tissue, it looks fantastic. But really, zirconia offers a biologic advantage. There's a lot better plaque resistance, less bacteria and biofilm adhere to zirconia compared to titanium. And also in that warm, wet environment of the mouth, zirconia implants will not corrode like titanium implants do. Think of like a car being left out in the snow and the rain and the heat and all those elements. Over time, it starts to rust. All right. But that doesn't happen with zirconia. All right. And that's a really important component because that corrosion process is one of the things that we believe may be associated with a condition called periimplantitis, meaning disease and inflammation around implants and bone loss around implants. That's a very common thing that I deal with as a periodontist these days. Um, Another advantage is also the fact that zirconia implants are hypoallergenic. There's a small subset of patients that have a true allergy to titanium, but there's a pretty significant cohort that has some level of sensitivity. So if we're putting a biomaterial in the body, we want to have something that's going to be as least allergenic as least reactive as possible. So that biocompatibility is really, really important. All right. And this is some of the things that as a periodontist, I see almost every single day with titanium implants. All right. I see titanium implants that are losing bone and are having biologic complications because now those threads are exposed and bacteria can get around it and it's very tough to clean. I'll see situations where there's corrosion, where titanium particles are coming off the surface of that implant, creating inflammation, a graying of the gum tissue. And it's even one of the theories of why bone loss starts to propagate 360 degrees around titanium implants. And of course, without saying the aesthetic considerations, right? There's so many patients who've had implants placed in front teeth. When they smile, what you see is that gray discoloration of the gum, and it's very, very, very hard to mask it. All these factors we see a lot less of with zirconia implants. And this is an important component of why I think zirconia implants are going to really be the dominant implant of the future as more and more doctors move away from titanium and learn more about the zirconia implant benefits. And with that, I want to get into some cases because I want to also make sure we leave time for questions. But I thought about cases that may pertain to the audience, things that people in the audience may have going on. And so I kind of share this. So I want to share the first case here, which is a single tooth in the back. It's a lower right molar. And this patient was starting to develop significant pain around this tooth. All right. And so I come back to my decision tree. Right. So I take a 3D scan and I see this large infection around the tooth, the gray area around the backside of the tooth. And the patient is in pain. I'm seeing a periodontal problem there. And so as I go through my decision tree, I realize that the patient does have these acute issues. So really, we got to go with the extraction only approach. And let's kind of go through that process. All right. So the painful acute perioendo lesion that this patient has means that the proper treatment for this tooth is to remove it. All right, and we follow the biologic tooth extraction protocol, that atraumatic extraction technique. And it's very important to understand that the whole area that's going to gray on the x-ray there, that's all infectious tissue. So it's very important to clean that out with the laser therapy, with the ozone, mechanically scraping that off of the bone so that you have a healthy site so that this bone graft can grow and adhere to that. And so then we'll follow that biologic tooth extraction protocol. And with proper healing, 3 months later, I was able to come back and place a zirconia implant into that site. It's very important not to rush, to do it properly, to work with the body, work with the biology. This is not a site that would have been acceptable for an implant right away. So we take our time, we help the body heal properly, and we have beautiful bone around that area. Once that zirconia implant integrates, we then can restore it. And on the right side here, we can see the x-ray of the final zirconia crown connected to the implant, as well as the appearance in the mouth. And this is an entirely zirconia system from the crown to the implant. There are no metal parts at all within this system, which is one of the most unique aspects of this implant system. And this is a patient who has autoimmune conditions. And so it was very, very important for us to be very selective with the type of implants we use. And I share this final picture of that site, which is from the 3D X-ray, the CBCT. And if you look at the area on the right, you can see around the implant, which is that screw located within the jawbone, how much bone is around that, how dense and how thick that bone is, how much denser it even is than the tooth on the right-hand side of the image. And this is that biologic extraction and regeneration protocol. When we follow those steps, the body builds beautiful bone, really strong bone around these implants that will serve them well in function. All right, and so this is the before and the after. You can see that large infection on the backside of the tooth and how well the body was able to heal that with the biologic extraction protocol. And then you see the zirconia implant placed the bone growing over the top of the implant, and you have this wonderful restoration. That's what I call biologic surgery from A to Z, from atraumatic extraction to zirconia implant. This is what we want to accomplish every single time. I'll transition now to another case, a front tooth. All right. And one of the things I will always say, whether you are a patient or you are a doctor, the closer the teeth get to the front, the more complex the case is. All right. Front teeth should only be handled by specialists, in my opinion. And I say this not to funnel work away from any good dentist, but because of the importance of managing the tissue, not only from a health perspective, but also from an aesthetic perspective. And I'm going to kind of show you some of the things that we have to do when we deal with front teeth. So this is an example of a patient who has her upper right front tooth. It's the left tooth on the image as we're looking at it. It has an infection. It's a root canal treated tooth that's failing. And as I go through my decision tree, fortunately, this patient does not have any pain and there's no periodontal infection around it. The gum is healthy. So I move on to that second criteria and I notice, hey, there's no buccal plate. There's no bone in front of this root because the infection has eaten through that. So once again, I cannot continue and I cannot say, okay, no problem. Let me go put an implant in here. Even though there's plenty of bone at the apex that I can anchor into, it's very important to know that you got to pull back here and you just got to do the extraction. And I'll show you how we do it. All right. And by the way, I practice in Manhattan and Greenwich, Connecticut. Nobody leaves my office without a front tooth. It's kind of a rule, an unspoken rule. So I'll kind of share how we do it. So it doesn't mean that just because we can't put the implant in right away means you have to go without a tooth. All right. What we end up doing in this case is that we took the crown of that tooth, meaning the part that we see, and we've cut it off from the root. We've atraumatically removed the root, right? If you notice, the gum tissue is entirely intact. And very importantly, those little triangles of gum tissue on either side next to the adjacent teeth are perfectly intact too. And that's critical for aesthetic success. All right. And then we take that tooth piece, we seal it off from the apex, and we bond it to the adjacent teeth. And on the image in the middle, you see an x-ray of that. So we see what's left of the tooth that was there, and you see the bone graft in the socket. All right. After 3 months, we take a 3D scan and we can see how beautifully the body has healed the bone. We have a great ridge of bone to work with where before we had no outer plate of bone. All right. And this is not magic, this is biology. All right. Working with the body to help it heal is the key to success. When we go here and we then can place the zirconia implant, I will now share what I do as a periodontist that really differentiates my approach when it comes to aesthetics, because this is why I say the front of the mouth is the most complex. When we place implants in the front of the mouth, it's very important to add more tissue volume to be able to create a thickness of the gum to help support the bone volume and to support the aesthetic position of the gum tissue so that we don't have recession. So what happens here is I'll make a small little portal. I'll make a little pinhole high up in the gum line, and you can see my probe is connecting from the sulcus of where the implant was placed right through a small little hole high up in the vestibule, and I will take a connective tissue. Connective tissue is soft tissue from the palate that we will use to create the appropriate volume of tissue on the front of that implant. And we do this through an atraumatic technique with the palate, and we make a protective stent that makes the process really virtually pain-free. But what I'll tell any patient is that if you are getting an implant in the front, it is worth the investment of time, effort, and procedure to do this right. Because fixing this down the road is the most complex surgery I have to deal with almost every single day. All right. And I always wish that if they just did it right the first time, it would be much easier than trying to come back later and fix that. All right. So this takeaway point of adding the tissue, and we're in the front, we have to do one extra step, one extra biologic step, bring living tissue to that area to create greater vitality and greater protection to that implant. When we do that, the image on the left is a top-down view. You can see that little bump of gum that gets added. Instead of being a depression or a concavity where the tissue would fall in, what we see is the gum in front of the implant is just as far out as it is on the natural tooth just adjacent to that. All right. And then when we take an impression of that, we can then make a natural tooth that will look beautiful, that will be synergistic with the body. And this is, again, another zirconia implant with a zirconia crown that's connected together, actually with a screw, meaning that it's connected in a way that we can retrieve this if we need to take it out. And it looks beautiful. The patient's very happy. This was a complex case. This was a 29-year-old patient, and we have to think about what would look good, not just now, but how do we preserve her aesthetics over the course of the next decades? So thinking long term. All right. So when I said to her that doing this tissue would protect this implant and protect this tissue for decades to come, it became a no-brainer. And I'll share a last case. Last case really more so as concept. So although most of the time zirconia implants or root canal extractions will be managed a tooth at a time or maybe one or two teeth at a time, there are some patients maybe here or there may be patients that I see every now and again that have a full mouth of root canal treated teeth that are failing. And we need to appropriately address that and properly address that. And there are techniques and there's approaches that we do. We follow the steps exactly the same. Atraumatic extraction, biologic detoxification, regeneration of those sockets, placement of zirconia implants immediately if it checks all the boxes, delayed if it doesn't. And we can take a patient like this who has multiple, a full mouth of failing root canal teeth, and we can transition them to a point of health and stability. And I'll kind of show you how we do it area by area. So this is an example of the upper right. We can see failing root canal teeth here due to decay, due to broken post spaces, fractures. And what we will do is we will stage the process where we will make it temporary on the teeth, even preserving or leaving some of the better quality root canal teeth temporarily while we rebuild bone in the area. This is important because if we become overly aggressive, if we just remove everything just because it is a root canal, we actually will lose more bone. We'll create more harm than good. Even though the intentions are right, the consequences are wrong. And that's why it's so important to understand how we can work with the biology, preserve certain things, certain structures, while we can rebuild others, and then transferring that support and stability to the dental implants when they're ready to do so. So this is an example of how we rehabilitate the front. In this case, we were able to remove the failing root canals simultaneously because there was not extensive infections beyond the apices. We were able to interject in the process early enough on these teeth that there was no significant infections. It was just poor crowns and leakage of the margins. And therefore, we were able to put those implants in right away. So there are 4 zirconia implants here in the upper anterior. And if we look at this case from before to after, we see how we transition all those root canals, all those diseased, all those sick, infected root canal teeth into zirconia implants. All right. And that gives us the ability to help now stabilize this patient's bite and rehabilitate the patient's not only oral health, but systemic health as well, because all that disease, all that inflammatory burden is gone. All right, and this is a view of what the restorations look like when we take an impression of the dental implants as well as the teeth and what the final teeth look like. Zirconia is beautiful. It is natural. The tissues love it. The aesthetic results are really, really phenomenal. And so with that, I want to say thank you for the attention, and I'm open to questions. I'm more than happy to connect with anyone and answer any kind of question, whether it is even kind of beyond the scope of what we're talking about here. But I think that just having your time and attention today has really been fantastic. I practice in Manhattan as well as in Greenwich, Connecticut. I'm leaving my contact information there, so you can feel free to get in touch with our office if you'd like to set up a consultation, whether in person or virtual. You can follow us online as well. And I want to open up the floor to any questions.
Yeah. So we had a bunch of questions come through, about 15 I have so far. So,
Good.
and right now, if everyone wants to go ahead and take a look at the bottom, you have a Q&A button. You can click that there, and I will read out your questions to get answered live here. But I'll go ahead and get started. Thank you so much. That was a beautiful presentation and very informative. I think all the hearts and thumbs ups that were coming through was a good representation of everyone's experience during that lecture. It was really informative. So thank you so much for that.
Thank you.
Okay, first question. I'm planning to remove a root canal tooth number 8. It was done 7 years ago. I'm feeling some throbbing. Would getting a flipper be a good option?
Yeah, so that's very similar to that second clinical case that we shared. So, tooth number 8 is a front tooth. It's in that aesthetic zone area. Um, if we're feeling pain, it means that things are probably more acute, things are probably more advanced. It's very, very likely that that's not a good indication for putting in an implant right away. So, that's why the conversation about a flipper is coming up. What a flipper is essentially a removable kind of semi-partial appliance that'll sit on the palate with a little tooth in the front attached to it that a patient would essentially flip in and flip out, to use it. It is, I would say for all intents and purposes, it is absolutely a workable way through the process. One very, very important part of and why I don't like flippers personally is that I find that they put pressure on the soft tissue and the bone healing. So if you are going to get a flipper, it's really important that the dentist adjusts it so that there's no pressure on the gums. Because if there is pressure, you're not going to form bone. You're working against the biology. All right. So sometimes there's other alternatives. For example, an Essex, which is an appliance like an Invisalign tray, they'll sit over the teeth. Or if there's a possibility to do a fixed bridge, depending on the condition or any work that's potentially being done to the adjacent teeth, that's really the best way to handle it because you will then have absolutely no pressure on the tissues. And that's the key.
Okay. The next question is, what's the difference between a cyst and an abscess on a CBCT? Can you identify via CBCT what kind of radiolucencies are actually affecting health and which ones are actually benign?
Yeah, so that's also a really good question. So a CBCT is a 3D X-ray, and that's what's really, I think, in my opinion, has changed the endodontic literature. Right. So going back to the beginning of my presentation, I kind of said, like, look, old studies we're saying 97% survival rate. Well, back in 2004, everything was done on two-dimensional images. We didn't see all the things we see now. 3D X-rays really kind of made us really scratch our head and be like, maybe these root canals aren't working as well as we thought they were. And so the next question then becomes, well, how do we know what's failing and what isn't? Well, I'm going to kind of frame it this way. The only way to know exactly what is in that dark shadow is by doing histology, meaning the tooth has to come out and then you take that sample and you go and test it. A cyst technically is an empty space, meaning there's a lining of epithelium and there's nothing in it. All right, like think of like a balloon filled with air. All right, and an abscess is a water balloon. It's epithelial lining with infection inside of it. If that area is persisting, meaning that the tooth has had a root canal or the tooth has had decay, and there's some shadow that's beyond the apex there, it's very likely that there's some type of disease process going on. Whether it's a cyst, whether it's an infection, neither of those are conducive to good long-term health. And so that should be removed and that should be addressed.
The next question, a dentist told me the PDL comes out automatically with the tooth. I guess that's not true. What if he did a comprehensive debridement and scraping?
Yeah, you gotta work at it to get the PDL out. It does not come out with the tooth. The PDL, the periodontal ligament, is actually a part of the bone and the tooth. So when the tooth is removed, you will take half of it out, but the other half is still connected to the bone. Scraping is definitely one of the ways that you have to get it out, but it is hard to know that you've removed it entirely. What we look for, and one of the reasons why I like to utilize the laser to do that, is that I know that if I can get through the first layer of bone gently without damaging it, right? And that's the key. The laser allows me to do it gently as opposed to scraping and pushing hard on it. I can see when I start to get into the marrow space because there's going to be bleeding there. Bleeding means it's alive, right? If there's no bleeding, it's not alive. And so it's very, very hard to achieve complete removal of the ligament just by scraping alone. You're right. It would probably, my guess would be that it should be at least 15, 20 minutes of scraping. And even then, probably something gets left behind.
Okay, perfect. The next question is, what methods do you use to diagnose whether there are any cavitations present?
Yeah, CBCT scan is critical. So going back to what we were talking about in that previous question, a 3D X-ray allows us to see what's happening inside of the jawbone. So that's step number one. And number two, our practice actually now works with a company in Germany to do a visualization of cavitations, a process called visiogenics. And this allows us to send that scan data and analyze if there's any presence of cavitation by putting it through an algorithm that takes a look and compares bone density of that cavitation site. Because one of the things that's always frustrated me is that when I've talked to a lot of different biologic doctors, we look at the same x-ray, and some people say there is a cavitation, and some people would say that there wasn't, and they wouldn't know, well, this one's a big one. No, I see a small one. There's no easy way to just calibrate one scan to the other without having this technology. So this is something very new. This came out actually in the second quarter of this year. And I think it's really going to be a very important visualization process and also surgical planning process. And it's one of the things we do in our practice with cavitation patients.
Thank you. When going through the immediate versus delayed implant, is the decision made at the time of the extraction, or will X-rays make that available to have more of a planned approach?
Yeah, it's you always go in with a plan, but you need to also have a contingency plan, right? So the CBCT scan prior to the extraction is very, very important because it can let you know about things like the presence of the buccal plate, the presence of the apical bone. So if you see that there's a greater chance that you will be able to do it, but you cannot guarantee that you do it because you need to be able to atraumatically remove that tooth, right? And so if that tooth is not removed in that way and there's damage to that buccal plate, then it's very important not to try to force the implant in. So what I always tell the patients, I say like, look, we're always going to plan to be able, if I think that they're a candidate for it, I say like, look, we're going to plan to do it, but there's a chance that we may not be able to. All right. And it's much better to be able to plan it for the long-term health as opposed to trying to force something in because you told the patient you're going to do it and then have an aesthetic or even worse, a biologic compromise down the road.
What testing do you recommend for patients for biocompatibility?
Yeah, so biocompatibility testing is an interesting question. There are a few tests that are out there that can help give a semblance of understanding of sensitivities to different materials. All right. None of this is foolproof or 100%, but it gives us a better indication than just kind of going in and putting some material and seeing how a patient does, especially in today's world where zirconia implants are much more standardized. But the titanium implant world, as I said, there's over 350, there may be almost over 400 implants now that are out there with almost any mix of metals and materials and alloys that are present, that it's so hard to understand the purity of that. Titanium implants in the 80s and 90s were made from commercially pure titanium. There's a lot less reaction with that which is why those implants actually tend to do so much better long term than even titanium implants today. All right. Modern titanium implants are getting people sick. All right. And that's a big issue. So, doing some of those biocompatibility tests, that's really, kind of the key way to do it. We incorporate DNA connections in our practice as a way to kind of look at that, and to take a look at it on the DNA level, meaning that we will draw a blood sample, we will run it in an assay, and we'll kind of compare it to a plethora of dental materials, about 13,000 different dental materials right now, and we will be able to kind of get some ideas of that. But we shouldn't make our decisions entirely based on that alone.
What is the percentage of compatibility of zirconia to the general population? I'm getting some resistance in getting some biocompatibility testing done from my biologic dentist.
All the main zirconia implant brands are part of that biocompatibility panel. So and just to kind of name a couple of the common brands that are out there, Swiss Dental Solutions, SDS, Z Systems, Zarimax, right? These are some of the common zirconia implant brands that are here within the United States. All those are available within that biocompatibility test. So there should really not be any pushback to be able to do that if that's something that you'd want it to do.
Especially if they're biologic, Christine. So, most biologic dentists, especially the ones on our platform, all the vetted biologic dentists that we work with, everyone offers biocompatibility because that is kind of a foundation and something that, all patients should have access to before they get permanent materials. The
Yeah.
next question is, once the root canal tooth is extracted, how does the patient know that the infection's completely cleared before getting the replacement implant?
Yeah. And so I'm going to kind of answer this question a little bit esoterically, and then I'm going to kind of dive in, but I think it's important. There is no surgery, and I'm a surgeon, right? So I'm going to kind of bash myself here a little bit. There is no surgeon and no surgery that you can do that is going to make up for what the human body has to do itself. What a surgeon does and what a surgical procedure is all about is to try to tip the scales in the favor of your body to be able to heal itself. All right, I'm going to say that one more time. Surgery is about helping the body heal itself. All right. So when we remove a tooth, we may not be able to remove every single bacteria that's there. And even if we did, you have to understand that there's bacteria that has entered the bloodstream, all right, that we are not reaching by cleaning out the socket alone. So what does? Well, it's that immune response. Inflammation is helpful to protect the body. Inflammation is helpful to get rid of any bacteria that enters the blood or any bacteria that's left behind. But if there's an overabundance of that, that's when it's too much of a burden for the body, and that inflammation can create dysregulation both locally in the mouth and systemically. So the key here is to do a really thorough job. And the concept of biologic dental extraction is to take the level of dental extraction and put it under a magnifying glass and do each step to the nth degree, to the best possible way to allow that body to heal. But then also think about it even more. And this is one of the great things I think about the oral biologics team is that even coming into surgery, you should be prepped for that. There should be the proper coaching of what you need to do to prime your body to have a successful operation, as well as the proper recovery process. For patients in our office, we go through that. We may do testing like vitamin D testing with patients. We may take a look at their labs and blood reports. We may get just a general sense of, are they strong enough to be able to go through this procedure right now? I had a patient actually right before the holiday on Wednesday that came to the office ready to do a big procedure. And she just came out of the hospital and she was not breathing well. And what I realized is like this body, this human is not ready to do surgery. And that's very important to understand that. So I'm very, as a surgeon, I feel that it's very important to be humble. I'm I have good hands, but they're not magic. And I'm good at what I do, but I'm not God. All right. What I'm here to do is to help, to do God's work through my hands, to be able to help patients. And it's so important to set the stage properly, right? Pre-surgery, during surgery, and afterwards. So I know it's a little bit roundabout, but it's one of my most important points that I really try to get people to understand, that it's so critical to understand how the body works when it comes to surgery.
Yeah. No, that's exactly why we started offering that service for patients because for members, we just realized how many members, even if you're seeing a general dentist, a biologic dentist, wherever you're going for your treatment, we want to be able to support you. And so, Melissa put together beautiful protocols and really focuses with patients on how to best help them get prepared for the surgery and also post-op recovery, because that's another thing, patients always have questions and things for their dental office. And sometimes, you need a little more hand holding, especially when you're recovering and there's a lot of sensitivities or you have a lot of um, medical conditions or things like that that, kind of take a big toll on the body. So definitely, thank you. Yeah, that's definitely something that we promote.
Yeah, I can't
Um, uh,
emphasize that enough. I think that that's so, so important. Um, Proper dental healing, proper dental surgery is a team effort, and so that's as any patient who is facing surgery, or has an infection or a tooth that's kind of bothering them. I think it's really important to understand that you have to get into this proper funnel to have good, lasting, long-term outcomes.
yeah. Okay, next question is from Angie. Can using an electric toothbrush along the gum line where the tooth and the gum meet cause gum recession? I feel like since I've started intentionally honing in on this area, per my holistic dentist hygienist recommendations, my teeth that don't have gum recession, I'm starting to see a little more of the tooth and it looks dangerously close to exposing the dentin. I've only been doing this for about a couple weeks, but what are your thoughts? Can this happen in some people? My hygienist said that my gums are a bit spongy.
Yeah, so it technically should not happen, or biologically, if it does happen, that small amount of recession that would happen from the trauma of brushing should be able to regenerate itself. But what do we see in the real world, right? In the real world, we sometimes find that patients will take an electric toothbrush and still use it like a manual toothbrush, right? Meaning that you're still scrubbing and moving your hand back and forth, even though it's really the brush that's supposed to do the work. So I don't know if that's the case, but if it is, pay attention to that because that will create recession. Second of all, there are some electric toothbrushes out there that have pressure sensors built into them. I know the Sonicare one has that, the Oral-B IO toothbrush has that. These are both great brushes to use because it gives a little bit of feedback when there's too much pressure. I brush with the Oral-B IO myself, and so, and I pay attention to how much time it's in the green zone, meaning it's the right pressure, and the red zone when it's too much. And I will tell you, sometimes I'm rushing and a little bit late to work, and there's a lot of red zone there, and that will create recession. So, having that will be really helpful. If there is a little bit of recession, all right. It's important to try to get a little bit of coaching and modification of those habits. That's not part of this lecture, but one of the things I talk about when I discuss gum recession is that if you catch it early, there's a lot of great ways to naturally reverse that. All right. And that can be done even by using simple things like either a saltwater rinse and a more gentle brushing, like a less abrasive toothpaste, like for example, like Biocidin, or Risewell, for example, that'd be really good. Or sometimes you can even use products like Stella Life that can help actually hydrate and rejuvenate some of the gum tissue as well. So these are some of the things that I'll use when it's kind of really early catch and it's reversible.
I let my dentist try the laser on me and it was painful. He said that doesn't happen very often. Why do you think that could have happened?
Um, Maybe we'll come back to that question. Give me a little bit more insight. What was the laser used for? That's, was it used for like a gum cleaning procedure? Was it part of LANAP therapy? If you can give any more information, I'll be more than happy to answer that.
Next question, I'll likely need a sinus lift after tooth number 14 is extracted next week. Is this compatible with having a zirconia implant placed after healing 3 months later?
Um, the zirconia implant, I'm assuming, is in a different spot than where, tooth number 14 is. Is that kind of the idea?
I will likely need a sinus lift after tooth number 14 will be extracted next week. Is this compatible with having a zirconia implant placed after healing? So I think the same
Oh,
site. She's
yes,
asking
yeah, yeah, yeah. Gotcha,
after
gotcha.
healing for 3 months, can she have an implant placed?
Yeah, so most likely, so a sinus lift procedure is a procedure that's done when a upper molar or premolar tooth is removed, and there's not enough bone to just put the implant in the natural bone. So we have to kind of lift the sinus, which is kind of this airspace that's above that. It, depending on how much bone you have remaining, is really what determines how quickly you can come back and place the implant. My recommendation generally, when we do a staged approach, meaning we're doing a sinus lift and then coming back for an implant, usually we're doing that because there's not enough bone to put that implant in. And so I will typically wait about 6 months before scanning you and seeing that I like the bone density. And if I do, then I'll place the implant. And if it's not what I need yet, or it's not dense enough, then I will wait a little bit more time. A sinus lift is a very predictable procedure. It's a very biocompatible procedure. And it's one of the best ways to ensure that you can get a appropriate sized implant in the back of the mouth. I love that your dentist is talking to you about this because so many times I see dentists try to avoid that and place these small implants in that area. And I'll tell you, they all fail. All right, small implants, especially small ceramic implants, there's not enough surface area. So do a sinus lift, wait enough time to have enough bone in there that you can have a good, appropriate size implant placed into that area, and that will serve you well long term.
Ursula, I see your question. She asked about the protocol for bone regeneration. She thought maybe she missed it earlier in the presentation. You did. So I'm going to skip past this one. So you can definitely watch this on replay as soon as tomorrow on the Aura Biologics platform, just because I have a ton of questions coming in here. So I just want to be able to have enough time for everybody's questions. But one of the questions also was that implants don't last forever, correct?
Yeah, so a dental implant may not last forever, right? And, I want you to kind of think of it this way. The reason why you need a dental implant is because your tooth didn't last forever, right? And so if your own natural tooth, which is the most biologic, the most biocompatible structure you can have, way better than any implant and way, way, way better than any root canal, if that is not lasting your entire life, it means that a dental implant can succumb to the same issues. But with that said, it's very important to understand what factors lead to implant failure, right? Luckily, implants don't get cavities. All right. Implants don't typically, it's extremely rare for them to fracture. They'll never have an endodontic problem. All those issues will not plague it. But what will be a common issue with dental implants is gum infection or gum problems. So it's really important that you have regular maintenance after the placement of a dental implant. I would recommend every 3 months for you to be in to see your dentist, for them to clean all your teeth, but especially around the implant. And I strongly advise that they talk to you about a protocol specific for hygiene around a dental implant, like using a water pick, for example, to make sure that you ensure the gum health is pristine.
A dentist indicated the back lower right tooth has an infection. How to determine if infection can be corrected or if the tooth should be extracted? I've had issues with this tooth for about 4 years.
Yeah, so a comprehensive evaluation is really the key. So I would say, one of the things we do in our practice is something called the ROSA screening. It's this very, very in-depth assessment of everything that we can see that pertains to both oral and systemic health. So I don't know enough about your tooth specifically, but what I would kind of say is radiographically, right, the R, right? So taking a 3D X-ray can help understand if there is anything structurally wrong with the tooth internally, or if there's any infection that's propagating beyond it within the bone. For example, pertaining to this lecture with the root canals or the infections around the teeth, they are very, very, very commonly missed in conventional two-dimensional X-rays. Right, so a 3D X-ray is my gold standard. I'd recommend that. Then an oral assessment, really taking a look throughout the mouth. What other factors can be affecting it, right? For example, it could be your bite. Right? There could be ways that your teeth are aligning orthodontically or such that is creating additional stress or additional problems with that tooth, right? The tooth can be otherwise healthy, but it's getting, traumatized by the bite. That can be one aspect. There can also be microbial imbalances, salivary imbalances, and so we kind of want to look at that as well. So I think really kind of dive deep with your dentist and have them educate you, have them show you what's going on, right? And I always kind of say, like, I always want to work on an educated patient. The dentist should sit down with you. They should go through the image with you, explain to you, hey, this is what's normal, this is what's not, and help co-diagnose the issue with you so that you leave understanding not only what's going on, but then this way you can make an informed option about what to do about it.
The next question is from Joanne. I have a root canal tooth for 7 years. Joanne, pardon me, I am the worst at trying to pronounce these long words, but she said I had laryngopharyngeal reflux
Mm-hmm.
afterward and to this day. Besides this, the tooth seems okay. Should I consider removal? Number 31, I'm 72 years old. Since it's the last tooth, I probably won't get an implant, I guess.
Yeah, so multi-part question, right? So, first and foremost, just to the tooth itself, all right? Let's deep dive that. Again, same concept, 3D X-ray, oral assessment, see what's going on with it, right? If there's something wrong with it, all right, make sure you do all the right diagnostics to figure it out, kind of pick it up, and that's going to be able to kind of guide you with where to go from there. If there is infection, right? If there's signs of failure, whether it's structural failure of the tooth or a biologic failure like an infection in the site, or even a gum issue around it, those that would predicate the removal of that tooth. Now, systemically, right? So the laryngopharyngeal spasms, right? These things can be coordinated either with any kind of inflammation that can be coming from that site or really your body's biocompatibility with the materials of the process that's there, right? Because the procedure has already been done, it's going to be very hard to know exactly what biomaterials have been done. So in this case, a biocompatibility test, like by Biocomp Labs, for example, is not it's going to be hard to get any kind of actionable data from that. So I think I'd rely more on the clinical assessment and really make sure you feel confident in what your dentist is presenting to you to make a decision about what to do with that tooth. The last part, the question about should you do an implant or not, it really depends on your bite. If you have all your other teeth, all right, and functionally there's no effect if that tooth wouldn't be there, meaning that you would be able to chew exactly the same because it's your second molar, an argument could be made that an implant's not necessary. But what I would also kind of see and share with you as well is that sometimes I see a domino effect where other teeth have not, maybe they're not the healthiest teeth, but they've been hanging on. And now this tooth is out. And all of a sudden now something else starts to fail. And then something else fails and something else fails. And so, if that is the case, if the other teeth in the mouth have some type of compromise, whether it's periodontal, whether it's restorative, or there's certain missing teeth, then it does benefit you to replace that tooth with a dental implant. And fortunately, that is a very predictable site to do it. Sorry, Kim, I think it might be muted here on your end.
Sorry about that. A next question is, I was born without one of my adult premolars. At the age of 26, I decided to get an implant to remedy the missing space. I had bone loss in the area because of the lack of tooth for so long, and so I had a bone graft. Does this create any complications with my titanium implant down the road for me considering my medical history?
Um, I don't know exactly what the medical history is, but obviously that would kind of depend a little bit. But speaking to the aspect of, the oral situation, getting a dental implant at 26 due to a missing tooth, it's a common situation where there's a lack of bone because no adult tooth was present there before. This is different than a situation where there is an adult tooth present that's, failing and you need to replace it with an implant. So it is very, very common that a bone graft needs to be done, hopefully done simultaneously with the implant placement. Based on the history here, it seems like it's been done later, done kind of secondary. And that might indicate that there's some level of bone loss that's happening around the implant. Once an implant, especially a titanium implant, has some degree of bone loss, it's extremely critical to ensure that no inflammation is present, meaning from a hygiene perspective, both at home and professionally. You focus on keeping it clean because that titanium surface is very reactive to the oral environment. And secondarily, what I showed in that case when how we handle front teeth when we place a soft tissue graft in the area, soft tissue has been shown to be more protective to dental implants, both titanium and ceramic, by the way, but it's more protective than bone. All right, so I would make sure that you kind of maybe check in with your dentist there, or be happy to consult with you a little bit about this if the right thing would be to actually add some tissue, some gum tissue to protect that implant.
The next question's a few different questions, so I'll just kind of read through the whole comment. How is it that root canals can have chronic infection for years without any signs or symptoms at all? Even a normal inflammation CRP. Also, would you say that a highly trained oral surgeon normally does an extraction very different from this, or are they now trained to do it without the trauma that you're speaking of? I would think that their additional training, their extraction process would be similar or no. I have spoken to a couple that mentioned PRP, but not ozone or the periodontal ligament. The periodontal ligament always comes up in a biological discussion, but I find it hard to believe that an oral surgeon would miss something like this and still do a traumatic style extraction. Thank you so much for such a wonderful talk.
Yeah, well, first of all, thank you for that. I'll do my best to kind of follow through. If one of those parts I miss, just kind of circle back with me. But first to kind of speak about the dental community and surgical community, um, you know, every surgeon is trained to clean the site of the periodontal ligament after it's removed. All right, so I want to make it kind of clear that that's not something that's special to the biologic community. That is actually dental extraction 101. The issue is a little bit with the care and attention to helping the body heal. In the biologic world, we focus on doing everything we possibly can to help the body heal itself. And that means removing that ligament so the body's own inflammatory process doesn't have to do it. In the conventional world, I know a lot of surgeons that do it the same way. All right. And so I want to kind of put it out there that I think there's a lot of great surgeons out there, whether they're biologically trained or not, that they should do that. But for some reason, there's also an idea, and it could be based on practice or training or whatever. There's a concept of speed in conventional surgery, right? And that a good surgeon is someone who can do the procedure fast, all right? And the problem with doing it fast is that it's not really about getting the tooth out, right? And that's why I kind of go back to my mentor's quote that I really like is, the work starts when the tooth is removed. All right. And if the surgeon says, well, look, I'm able to take out four wisdom teeth in 10 minutes, right? Or I could do it in 5 minutes. Well, yeah, I think that's great from a practice perspective or amongst, whatever kind of ego side those conversations happen. But the real problem is that that's not the work. The work is then cleaning that site so the body can heal. So I say it to like, I don't, if you have a surgeon that you really work with and you respect and you like, I want to let you know that there's many oral surgeons that I'm very, very good friends with, and we see eye to eye 101% about that. Um, to go back to the root canal question. All right. So when a root canal is done, all that vital tissue inside the tooth is removed. So the tooth has no feeling for any infection. And for example, one of the ways that we test if the tooth is dead, whether it's due to a root canal or due to necrosis or infection, is we'll put cold on it. We'll put something really, really, really cold on the tooth. And you know that kind of brain freeze effect that you'd get if you kind of bite into a popsicle or something and your tooth like really hurts. That's the response we're looking for. And if you have a root canal treated tooth, it will not have that. And that is an alarm system, right? That's your body's way to kind of tell you something's going on. All right. Unfortunately, a root canal procedure removes that, but it doesn't remove just the nerve. It also removes the blood supply, which is how the body brings cells to help fight infection. And so, unfortunately, a root canal treated tooth that sits around for a long period of time will be filled with a lot of toxic bacteria, and that bacteria will be leaking into the body. If your immune system, if you are super healthy, your immune system is really strong, it's not dealing with a lot of other issues, it's not putting out a lot of other fires, well, it probably can suppress and maintain the progression of that infection off the tooth fairly well and for a certain period of time. In your case, 7 years. All right. But I'd also be curious to say is if we were to take a look at what that looked like 7 years ago and today, has it progressed? Because an infection in the jaw is going to progress by increasing bone loss. So it means that the body is retreating. It's giving up bone to the infection because it can't get rid of it because it's inside of that tooth. And so you may not feel it and you may never feel it until it's too late, like you get an acute abscess or a big infection. So don't use pain. And this is not just for you, this is for everybody in the group. Do not use pain as a metric to know if your root canal tooth is stable or infected. The tooth does not have an ability to feel that, and the ligament and the bone are poor feelers for infection. They're not good at helping you know that. The right way to figure that out is to get a 3D scan and a clinical assessment. You just can't figure it out for yourself, unfortunately. I think I may have answered all the parts. If not, just ping back Kim with another question for anything that I missed there.
I think that you did hit them all. I also just wanted to kind of let everybody know. I know there was a couple of secondary questions coming through. I'm trying to hit every question, at least one question for each member. So I know there's some members that are sending in multiple questions, and I just want to get a chance to get each member one of their questions answered first before kind of going through a duplicate for another member. So we have a ton of questions on here, and we might actually, what I might do is have since they're continuing to come through. I don't want to
This
not
is
get anyone
good.
their
This is good.
answers.
Yeah.
Yeah. But I do just, I mean, we have probably another 10 or so to go, 15 to go. So what I think if it starts getting a little too late, what I'll do is I'll take all your questions, and then if it's okay with all of you, I can send you the answer in written form. And that might be helpful too. I know some have mentioned that the night is getting late and there's some kids to get to bed. So I completely understand that. But I'll go through a few more here. Stephanie, for your question, I'll connect with you directly if you'd like. You can send me an email at admin@aurabiologics.com. I'm happy to get you connected, or you can contact Dr. Alex's office directly. I know you're in New York and you were interested in seeing him. So definitely go ahead and reach out to the office and see if you can get connected with them on any questions that you have about the appointments. Susan, I have an adult non-speaking son with autism. His four wisdom teeth are pointing inward, lying on their sides. The teeth have not broken skin, no visible infections. Since he's non-speaking, we have to kind of play detective. He's had pain for these from these teeth. We are into holistic health, but this is a tough situation. We're consulting with a reputable oral surgeon on Tuesday. Is there a periodontal ligament under the wisdom teeth as well? And what can I do for my son for the best outcome and healing?
Yeah, absolutely. And kudos to you for kind of going the extra mile to make sure you do all this research. You have this appointment coming up, you're here on this webinar, you're doing everything right for your kid. That's really amazing. So, from one parent to another, great job. Yes, every single tooth has a periodontal ligament. Any tooth that's extracted, the periodontal ligament has to be removed. So these are kind of like solid tenets of anatomy and surgical protocol. I think if you will communicate with the oral surgeon, that's something that it's really important to address and clean out. I think they're going to hear you loud and clear. I think they know that. I will add one thing that is specific to wisdom teeth, and I'm happy to come back and talk about cavitations at some point to this group too. Cavitations. Um, Actually, I remembered one part that came back from the previous question. I'm going to tie it in here. So, in my presentation, I made a point to say that when a tooth is removed, it's not enough to just graft with PRF. And there's an old question about PRP. I'm going to put in the same category. So, blood factors as a category by itself, PRF, PRP, are not enough to prevent cavitation formation. And as it pertains to your son here going for this procedure, cleaning out the ligament is also not enough in an impacted wisdom tooth case to prevent cavitation formation. It's Given the young age, it's less likely for it to happen. But the best way to prevent cavitation formation, in addition to doing all the steps I showed in the presentation here, is ensuring that even wisdom tooth sites get grafted. I will say that this is probably one of the biggest areas that biologic dentists differ from oral surgeons. They'll take out the wisdom tooth and they'll say, what's the point? You're not going to put an implant in here. It doesn't matter. Well, I'm going to give you two important arguments. One, the purpose of the bone graft is to help the body rebuild the bone to support the second molar, the tooth that's still there. Because if you take out an impacted wisdom tooth, especially a horizontal impacted tooth, you can bet that there's going to be bone recession on that adjacent tooth, right? Why? Because there was no bone to be there beforehand. The tooth was there, it was impacted. Second of all, an impacted wisdom tooth. A wisdom tooth is a large tooth. And to remove an impacted wisdom tooth, you have to make a bigger opening to get it out. It's not like a regular tooth. You can't remove it atraumatically. You will have to open the gum. You will have to cut into the bone to get it out. So your risks for cavitation just went up way more. So it's really important after cleaning to do that biologic regeneration component, right? The grafting, the bone mineral graft with the PRF, that is super critical. And then the right supportive care afterwards, incredibly important. All right. So, please, and I think also speak with, the health coaches at Or Biologics too, because if your son's having that procedure on Tuesday, then there should be a protocol in place to support that process afterwards.
I have a question, and I just want to say, Natasha, I have Natasha and Angie. Both of you I know have multiple questions, so I'm going to choose one, and then I'm going to reach out to both of you. I have both of your contacts, so I can try to help answer some more questions for you. But one question, can surgically removing the abscess identify the type of bacteria present and injecting ozone and antibiotics into the tooth work to save the tooth so it doesn't have to be removed? I'm wondering if there's any other options to potentially save an infected tooth. Are there alternative options being studied or researched right now?
Yeah. So that's a great question. Yeah. If there was a better way for us to deliver medicaments to an infected tooth, we would be able to save a lot more teeth. And there is tremendous research that's being kind of looked at to try to help move that along because dental implants are not the future answer, right? Even though we talked about in this presentation, and I'm telling you that zirconia implants are the future of implantology, what I really hope is the true future of implantology is A, preserving your own teeth, and B, if we can't do it, is going to be regrowing your own tooth structure, right? So, that's where we're looking to get to, but we're not there yet. And unfortunately, we're not close yet either. So, what we have to focus on is we have to focus on prevention, all right? We have to prevent disease from propagating We need early detection, thorough diagnostics, and to really look at these things before they become an infection that's requiring root canal therapy, right? Or a conversation about that. All right. The challenge of ozone treatments or things like that is that because the infection is within the tooth and there's no blood supply there, there's no way for you to get medicine there, right? Ozone is not going to penetrate through the bone and into the tooth. Unfortunately, the bone is too dense, right? It's not going to get there. Antibiotics will not work because there's no blood supply to bring the medicine there. That's the biggest challenge of a infected root canal tooth. You have to think of it like an infected appendix, right? If an appendix gets infected, there's no antibiotic that can be used to treat that because there's no way to get a blood supply there. Unfortunately, it's a surgical procedure. It's the same thing with this dead tooth, right? So that's the key here, right? We have to prevent. If we can't prevent, then use the most biologic protocols to replace.
What is the success rate of dental implants? You talked about success and survival of endodontic treatment. How do implants compare, and what happens if an implant fails?
Yeah, so I'll give you some research about that. So conventional studies looking at titanium implants, which have just when why I bring that up is because it's really just a much more studied aspect. We have really big number data to support it. Is that we will kind of see 98% survival rate, which is similar to that endodontic study, 97, 98. In short-term studies, meaning less than 5 years, we see about 90% survival at about 10 years and 80% survival at about 15 years. All right. And why I talk about implant survival, all right, is that implants are a little less forgiving from that standpoint of survival versus success, right? If an implant gets an infection around it, it typically propagates pretty significantly and the implant needs to be removed. All right, it's not like a root canal treated tooth that's not going to be painful. If an implant gets infected, it's pretty painful. It's going to come out. So so seeing that the numbers are kind of better than what we see in endo, that's one of the things that kind of leans me always kind of more towards the implant side of things. Plus, if you look at the true numbers, the recent numbers of what you see with endo, it's actually quite scary. It's less than 50%, right? And depending on the tooth, it might be even less than 30%, right? So, and this is their own literature, right? And so, and I really commend them, first of all, for reporting that. I will tell you, a lot of research studies do not get published if the results are bad for the field. So to have these articles out there, I kind of commend their field for kind of being open and honest about it. And I think actually the field of endodontics is very bright. I think there is a future there in the regenerative side. They need to kind of get out of the business of kind of preserving dead teeth and get in the business of regenerating teeth. And there's a lot of research with that. And I think that they're going to be successful with it. So that will help. But, kind of getting into that mix and into that aspect, dental implants have been shown to have very good survival rates. A ceramic implant study, the best that I can think of off the top of my head, is a German study by the German Society of Periodontology. They looked at, I think, about 5 or 6 thousand ceramic implants at 7 years. And at 7 years, they were seeing over 97% of those implants still in place. So I think ceramic implants really are strong. They're the way to go. It's a generally newer technology, so we're not going to see 15 or 20-year studies yet, but there are so many patients. There's tens of thousands of patients, probably hundreds of thousands of patients out there with ceramic implants that are thriving with it. So, it really is the future for implantology.
Deborah, I saw you had a question. If you've already had a titanium implant placed and have no side effects, will that mean that you're compatible with titanium for future implants, or should you go with the zirconia? I'll just jump in here. I think, what Dr. V talked about earlier with the quality of what's out now for titanium and the different metals that it's made up of, as opposed to older titanium that was, solid titanium is what makes a big difference with today's titanium implants. So you can touch on this, but I think the answer is to, better be safe and go with the zirconia unless you had an allergy to it that you were aware of.
Correct, correct. Yeah, I mean, I think if you're facing the need for an implant, I think really barring some very kind of fringe scenarios, a ceramic implant will always serve you better biologically, right? It's really always the way to go. Where do zirconia implants not work better than titanium right now? On very odd angles, right? So if some patients who get these treatments like all on X or all on 4, where there's complex anatomy, you need to avoid it on angles. Zirconia implants are not going to thrive there. Zirconia implants need a biologic protocol around it. You got to rebuild bone, not resect it. So, but other than that, I would absolutely go with a zirconia implant if you have the option, even if you've been successful with titanium before. It just means that you're biocompatible to a lot of things. And hey, that's good. But why not put something in your body that's not going to corrode, right? That's going to be more plaque resistant, that's going to be more aesthetic, and it's going to serve you better in the long run.
Okay, I'm going to go ahead and finish off with the last two. And again, I took some notes for the questions that didn't get answered. So I'll reach out to both of you and kind of get those answers to you. Specifically, Angie and Natasha, I know you have some additional questions. From Jill, what is the risk of hitting or injuring a trigeminal nerve and that it will lead to chronic and permanent neuropathic pain, including myalgia?
Yeah. So I'm assuming the question is kind of pertaining to, implant placement, but, of course, it can also pertain with tooth extraction. It's very important to get a scan, going back to that concept of taking a 3D scan before doing any procedure, to know where the vital anatomy is. All right. If it's about placing a dental implant, it's very important to put the implant short of the nerve by about a 1 to 2 millimeter safety gap. Right. So you can measure the distance from the bone crest to the nerve. Let's say that distance is 12 millimeters. The implant should not be longer than 10 millimeters. All right. And that creates a little bit of a safety factor. That's something that I do personally with surgery. I create those safety factors. I think it's just a way to mitigate that risk. Now, with that said, your second question is, if it does get hit, what's the incidence of, neuropathic pain? The good news is that that's probably one of the more rare outcomes that would happen. It is more common to have what we call a paresthesia, whether that's temporary or permanent. It's like a numbness feeling. It's like when you get numb for the dental procedure, right? It kind of feels like that lingers a little bit. Pain is not a common response, although it can happen, but it is rare. It's more likely that the area feels numb. You should, if that happens, you tell the surgeon. The surgeon will back up the implant, meaning reverse the implant a little bit to take some of that pressure off, and that usually completely alleviates the issue.
Okay, and then our last question here, can zirconia implants be positioned where back teeth have been extracted many, many years ago, 10 plus, and there's been bone loss? If you need palate expansion, extractions, implants, what's the order of how that come, like which should come first?
Yeah, yeah. So, absolutely. The key is just rebuilding the bone, right? So, all dental implants require healthy bone. Zirconia implants require more healthy bone than a titanium implant would. All right. And the reason for that is because you need a certain size or dimension for the zirconia to be strong enough to deal with the bite. So the implants just tend to be a little bit bigger. And so you want to have enough bone around that. There's fantastic bone grafting techniques that we do that help rebuild the bone to make that possible. It may be done simultaneously with the implant placement, Or if the bone has been missing for a long, long time, or the teeth have been missing for a long, long time, it may have to be a staged process where there's two steps. First, you build the bone, then you come and you put the implants in. But I would say that more often than not, it's all possible. It's all very doable. You also asked about, I believe airway expansion, I think was part of the question too.
Mhm.
If there is any kind of orthodontic movement, whether that's tooth alignment to create proper spaces or airway expansion techniques, the key is to do that first so that the dental implant can be placed in the proper functional position. A dental implant, once placed in the bone, will not move. All right, it is fused and locked into the bone. Teeth are connected to the bone via that ligament that we keep talking about. That ligament can move, all right? And so those teeth will respond to orthodontic forces. So the proper sequence is to do any orthodontic or airway therapies first, create the proper space for the implant, graft the bone to have enough adequate bone in the area. I'm going to also say that if it's been a long time, you may even need to graft some gum so that there's protective gum tissue around the implant for long-term success, and then the placement of the implants.
All right. That was really great information. Thank you so much for providing, such detailed answers. I think this is the longest webinar we've had thus far. So many questions, many
Good,
members
good.
joining and really kind of being able to educate themselves and get the answers they're looking for. So thank you all for joining us tonight. We really appreciate it. Thank you so much, Dr. Volchonok, for sharing your expertise and providing such a powerful presentation. To everyone who joined us live, thank you. Before we close, I just wanted to give a quick update that the Aura Biologics platform is officially back up and live. So if you're not currently a member, I know some of you come from our Facebook or Instagram, we kind of have different avenues of how you find our webinars, but we do have our website back up and live that you can join as a member and have access to free resources, free webinars each week. You can replay any of these webinars, that we're hosting each week with the biologic dentists and other naturopathic and functional medicine doctors and things like that. So you have a lot of access to a lot of really great information, questions that other patients are asking, that might be similar questions you're looking to get answers to. And again, we always have resources like Melissa, who's the director of our health coach. She offers pre-op and post-op health coaching with patients one-on-one virtually. So you can be anywhere in the country. You can be seeing any dentist you want to see. But we want to be able to support you and provide you with protocols that could be helpful to make sure that you're healing properly. So again, thank you so much for being here with us tonight. And, our biggest mission is trying to make sure to empower you to be able to have as much education as you can so that when you do choose a dentist, you do decide to move forward with any treatment, you have a resource that can help, give you the own power to make those decisions and know what you're choosing is right for you. So again, thank you for joining us. Thank you, Dr. Alex, for being with us and having a beautiful presentation. If you want to connect with Dr. Alex, you can call him directly at his New York City office or in the Connecticut location. The New York City's 929-293-0200. You can also reach out to them on Instagram, Facebook, email them, however you'd like, but I'm sure he'd love to have any of you as a patient. And, he's a great provider to care for you and your root canal extraction needs or cavitation needs, anything that you have going on. So thank
Yeah.
you guys again.
Yeah, thank you. And I appreciate being a part of this and being able to present to all of you. Again, kudos to each of you for really taking your oral health seriously. It's such an important conduit to long-term health, longevity, systemic and oral wellness. It's my mission to bring the best aspects of this together between myself and my team for patients. I'm here for you however I can help. And I think it's just amazing, what Kim and you and Melissa are doing, to bring education to people. This is wonderful. So thank you for having me. I appreciate it.
Yes, thank you so much. All right, everybody have a wonderful weekend and we'll see you next Sunday, 6 o'clock.
Thank you. Thank you. Bye-bye.
Thank you.